Thank you, Hannah. I just want to do a quick check. Can you guys hear me okay?
It's great.
Perfect. And then let's see. I just want to make sure you guys can see my screen okay as well.
Yeah, go ahead and click slideshow and start your presentation. We'll make sure it's exactly the way we want to see it. Perfect.
Good to go. Okay. Well, thanks everybody. Good morning, and I guess happy Halloween. It's a pleasure to be here with you guys today, and excited to present some updates for you guys. As mentioned, my name is Eric Hawkins. I'm the state epidemiologist, and I think it was actually exactly a year ago today that I was actually officially taken over the title change of state epidemiologist, but was previously the deputy state epidemiologist for about 4 or 5 years through COVID. So it's been a pleasure working through a lot of the work here at the agency as we've continued to evolve over the last 7 years that I've been here, and especially since the pandemic over the last few years. So without further ado, I'll kind of move along here in the slides. I just want a quick touch on our IDOH mission and vision. As you all know, we are the state public health agency, so we try to help improve the health and safety of all Hoosiers, not just specific populations. So we're working in tandem with community partners as well as you guys, which includes all of you on this call today. Oh, I apologize, my phone's ringing. So just really briefly, I actually shared this slide in the spring as well, and thankfully we're still very similar to where we were in the spring with staffing wise. We're a large division. We have about 100 staff, which are mostly epidemiologists and infection preventionists. We have a large team of infection preventionists at this time. So we currently we're organized in a fashion that makes sense based on public health program areas and how we respond to different outbreaks and control of communicable diseases. But we have 5 epidemiology directors, and I saw during the preview of the session there was an overview of the HAI AR team, which is led by Trent Goley. He was new to us last year, but has been with us throughout this year. But we also have vector-borne zoonotic diseases led by our state public health vet, Jen Brown. We have a field epidemiology team that includes up to, when we're fully staffed, up to 20 staff to help and assist local health departments. We have our outbreak team, which covers vaccine preventable diseases, respiratory outbreaks, and surveillance, enteric diseases, and just general infectious or other types of outbreaks that may pop up. And then we also have the TB and refugee health and MBS surveillance team that fall under this division. So I'm very happy to lead this team and continue to grow this team into the future. So just a quick outline of what I'm going to try to cover today, and happy to answer questions at the end, or if you feel free to also email me or after this session too, if you have additional questions or want to just chat about some of the work that we're doing here. So I'm going to go a quick brief overview of respiratory, some of our respiratory infections that we're seeing this year, and sort of what we all look at throughout the respiratory season. I've got a few infectious diseases and other areas that I want to just touch on that may be of interest to you guys, and I also just want to give time to highlight some of the great work that we do here in our agency. If you haven't heard, Indiana is including, and IDOH is leading the charge in this. We have our initiative Health First Indiana, so I'm going to give some updates on that. And then just some regular, just general communicable disease rule updates that I try to cover each time we give a session like this. So just jumping off, as you all know, we're already in respiratory, sort of our respiratory season. So we're underway, and thankfully right now we're not seeing a lot of activity in any one area, but this is just a general reminder that it is respiratory season, and this is good for your community partners and patients and things that people that you're working with in the community. When we talk about a respiratory season now, we do include COVID-19, of course, and then we also have influenza and RSV that we now talk about. And this is a great overview. This slide is a great overview of sort of the vaccines that are available at this time. So the influenza vaccine has been out and available, and we recommend everybody getting that around September and through October. our COVID vaccine, again, September and October, and then RSV is we've got some new, as everybody's heard, we've got some new RSV vaccines that are available for adults over 60, also pregnant people, and then also infants and children under 8 months of age as well. And then just the general communication that we all like to provide around prevention is cleaning your hands, washing your hands, covering your coughs and sneezes, and then making sure that people are staying home when they're ill. All this latest guidance around some of this respiratory season and vaccines and what we need to know about each of these diseases is all on CDC's website as well. They've got some great resources available on throughout their web pages. So the first area I just wanted to touch base on is influenza. We thankfully we've got a new dashboard, and I know I highlighted this in the spring as well. But I just want to continue to highlight a lot of the work that we're doing here in dashboards and trying to make a lot more of our data more visually pleasing and available to the public and providers and our community partners. So this is our influenza dashboard, and we continue to improve this and hopefully continue to add more information as we go and learn more about some of the data that we do have. So right now, thankfully, influenza activity is minimal at this time in the state of Indiana. We haven't had any reported influenza-associated deaths at this point. I would anticipate that changing in the near future just based on where we're at in the season and sort of what we've seen in past seasons as well. Syndromic surveillance is not really high right now, as well as our sentinel surveillance. So taking a look at our ILI or influenza-like illness surveillance that we see, I want to highlight a couple things on this slide. So the map on the right shows the current activity as far as ILI goes, and really, what if you're not familiar with ILI, this is pulling information from hospitals, looking at their chief complaint data, and then we have algorithms that we look at within that chief complaint data to see why patients are going to the hospital, and we look for specific things that may allude to influenza type illnesses, including cough, sore throats, talking about influenza or complaining about influenza. So it's just a way for us to get some information on who's going to facilities. The green line on that graph there, that is last year's ILI activity. You can see around this time last year, we were pretty high as far as ILI activity goes. And then it peaked super early in mid-November, early December, and then trailed off and didn't really see an uptick again, thankfully. It's really hard to see, so I apologize, but there is a small yellow line there at the far left, and it's below all the other lines. That is this year's current ILI activity. So you can see that we're below where we've been the last 4 years, actually, as far as ILI at this point in time. But that just like any influenza season, it's really hard to do a lot of predictions about what we're going to see. So I take that with a grain of salt, but I do want to point out that our activity is lower than what we've seen in the last few years right now. So hopefully that's a trend, but we'll continue to monitor and share information as we go. So this is our ILI net, which is a little bit different than our Essence data that I just covered. So this is looking at select providers that we work with. They're called our Sentinel providers across the state that we collect information on. So they talk about, we ask them to send how many patients they're seeing and how many of those patients are actually coming on based on illnesses like influenza. So we use that information, we pull that information from those providers, and then we also ask them to collect specimens and send them in to us for testing as well. So this is a little bit different, still low. Sort of our threshold for ILI activity is about 2.5% of all patients going to a provider. For influenza-like illnesses, that would be where our cutoff is for threshold. Anything above 2.5% of those patients coming in for that for ILI is considered getting towards the higher end of ILI activity. So right now we're still below that threshold. We're still below where we were last year during this time. Again, you can see it kind of moving up, and likely it'll continue to move up as we go through the next few weeks. I just want to show a little bit on our influenza-associated deaths. I just mentioned that we haven't had any deaths reported on our surveillance yet this year. However, I just want to point out last year we did have quite a few influenza deaths reported to us. I will say that we are doing a much better job of getting reports from providers on deaths. We're also able to do a lot more analysis on the back end to look at a lot of records data and use some of that information to improve our influenza deaths. We're also able to get a lot more influenza testing results as well. So we're continuing to improve on that. So some of that was some of those increased deaths may be related to that, but also I think last year, I think just nationally, we saw a lot more severe illnesses with influenza, and a few different theories why that may be post-pandemic. So just want to point that out. We were already seeing some deaths the last couple of influenza seasons around this time, so I would expect we start seeing some of those anytime. So moving on to COVID, we're still utilizing this is our main COVID-19 dashboard. Thankfully, right now we're I think here nationally we're seeing COVID activity kind of starting to go down again. We were seeing some peaks here in the last couple months as we're moving into respiratory season. One thing I do want to point out on this, I think I covered this in the spring as well, but this is a great dashboard that we've moved to and probably use this for other things and as a model. But we're at the top there is our sort of our sentinel looking at hospitalizations due to COVID-19. Thankfully, this is the whole since the pandemic actually started. So you can see that we've thankfully not seeing as many deaths, but we still do see deaths for COVID-19 from this. That second graph is the COVID-like illnesses. So very similar to influenza-like illnesses, but different algorithms. So there we do separate some of those out. So we do look at that syndromic surveillance for COVID-19 as well. That tends to trickle up just like we see with hospital admissions. And then COVID-19 deaths, thankfully, we're seeing those low as well, but we're still seeing those. And then COVID-19 case surveillance, we're not relying on that as much as you can imagine we're doing, because there's a lot of at-home testing. A lot of people don't get tested anymore, but we do keep it up there for right now as a comparison. And we can likely move away from that into the future as well, because all these other data points we're going to continue collecting as well. Then that bottom one, the purple graph, which I mentioned, I want to point out is wastewater surveillance. We're going to attempting to continue this through into the future, not just for COVID-19, but we're going to add some additional pathogens that we're going to be testing for with wastewater surveillance. So more to come on that, but I did want to point that out that as you see the trends in like case numbers, we don't see a lot of variation anymore, but you can definitely see it in wastewater surveillance and some of the other surveillance that we're doing. But you can see that our in the last couple months, we actually saw quite a bit of COVID-19 activity, or SARS-CoV-2 to be more exact in our wastewater surveillance. So that was pretty high, and going back even until last year, we're seeing similar levels this year in our population. So I just wanted to point that out. And then just another highlight on our wastewater dashboard that we have still active. We are getting water samples, wastewater samples from 22 plants across the state. We've tried to get a good representation across the state so we can get a good sample there. We've seen wastewater going up, and thankfully going down right now. You will see a couple of those districts are red, still seeing some activity in those areas. So, but we're pretty proud of this wastewater surveillance, and like I said, we're going to be adding some additional things. Hopefully, influenza in the future, potentially RSV, and some other things. I know CDC has done some Mpox testing in wastewater as well. We don't have that on our dashboard, but more to come on wastewater. I think this is something that CDC will continue to help funding for us in the future across all states, and we'll continue to use it as a surveillance tool moving forward for everything beyond COVID. So just a quick update on COVID-19 vaccines. I'm sure you're all aware, but there's a new formulation for COVID-19 vaccine that's out and available for boosters this respiratory season. It's been out for a few months. But it's been updated to a monovalent vaccine, and it's based on the Omicron XBB.1.5 sublineage. So it's been updated. All the original monovalent, bivalent formulations should no longer be used. They're no longer considered to be good for use as far as preventing illness. And then there are different manufacturers, of course, for all these vaccines. And right now, there's no preferential recommendation. It's just if it's available, then we should be getting that vaccine or providing that vaccine to our patients. This is a really cool tool. If you haven't been on it, CDC has a great tool, and this is going around to all respiratory illnesses, the big three that we continue to talk about. We currently in Indiana don't have RSV. It is not reportable in the state of Indiana. I don't plan on moving anywhere towards that right now. But it is important to note that there is some data on RSV, and CDC right now is showing some of that data. So they have a network of hospitals across the country that they're looking at some of this data. So they're getting information on RSV hospitalizations, COVID hospitalizations, and influenza hospitalizations, as you can see on this graph. But it's a really cool interactive tool that you can use and break it down by those three different pathogens. The dotted lines on here, so the black dotted line or dashed line is all respiratory illnesses combined. Then that's last year. That is not this current season. So that was last respiratory season. The red dotted line or dashed line is the COVID-19 updates or surveillance. The blue is influenza. And then the green is RSV. On the far left are these solid dots. So the black, red, and green are the solid dots. Those are for this year's surveillance. So as of right now, the activity within those respiratory pathogens are lower than they were at this time last year, but that doesn't mean that that won't change in the near future. So we just need to be prepared for that. CDC is also doing a lot of work around building tools and things for states and local health firms to start using in the future. There's not a lot of it out there now, but there's a lot of talk and work going on around it. And that's around modeling and forecasting, especially around respiratory illnesses. And one of the things they continue to talk about is right now, there's not a lot of activity. And one of the things that they're building into these models is if we see these pathogens, these three different pathogens sort of peak at different timeframes, that's probably the best case scenario. But one of the things they look at modeling is what happens if we see a peak in all three pathogens at the same time? What does that do for hospitalizations, and what can we use that data for to help prepare hospitals in the future? So definitely some work being done around that, and some cool activity being shared, but more to come on that. But like I said, if you haven't been to this, the link to this dashboard is actually at the bottom of this, the bottom of the slide, and feel free to go and check that out. Just another screenshot. So this is actually just a break that just gives you a little bit more detail where this came from. You can actually go onto this dashboard and do different filters. You can look at different seasons and look at it by different pathogens as well. Also, just a bit more information on RSV here. There has been recently some MMWRs released from CDC about RSV. So just a couple of summaries here and links to those articles down below. This one's looking at the characteristics and outcomes of adults that are over 60 years of age and who were hospitalized and laboratory confirmed with RSV. So this information shows who's most at risk for being hospitalized if they do have RSV. So this report was actually looking at obesity, COPD, and congestive heart failure as some of the underlying conditions that increase the chances of somebody or likelihood of someone being hospitalized with RSV. So this is giving information, and it helps to paint the picture of the importance of having an RSV vaccine, especially for individuals that are over 60 years of age. A second MMWR around RSV came out as well. This one's looking at the, excuse me, I still have a little bit of a respiratory illness myself. So the severity of RSV among hospitalized patients when you're comparing COVID-19 to flu. It's another great resource that's out there. But this report, kind of the additional information that this report gave is hospitalizations for RSV were less frequent, but associated with more severe disease than were hospitalizations for COVID-19 or influenza. So that includes interventions while they're in hospital, including oxygen therapy and intensive care unit admission. So again, this is leading to the points I'm painting the picture again why RSV vaccination is important for older individuals specifically, just because due to the nature of the severe outcomes when somebody actually is hospitalized with RSV. So I'll moving on to a couple of different topics, other infections, non-respiratory infections. The first thing I wanted to mention to this group and that we've recently been looking at is we've actually had 7 new Mpox cases. Mpox, if you're formerly known as monkeypox, but we've moved away from some of that stigmatizing language nationally. So Mpox is the official terminology that we should be using for that condition. But since October, so just this month and the last couple of weeks, we've actually had 7 new Mpox cases, and that may not seem like a lot if you haven't been following some of the Mpox outbreak nationally and internationally over the last year or so. So as you can see, this is our dashboard here. In mid 2022 is when we really saw our Mpox outbreak nationally going on. This is Indiana specifically, so you can see that we had quite a bit of activity last year, about a year and a half ago. But then all of a sudden we have these 7 new cases out here at the end of this year here. So quite a bit of distance between those. So we are investigating some of these. It's important to note, and the reason I'm bringing this up is because we actually haven't seen, we haven't had an Mpox case since July, so several months ago in the state of Indiana. And this has happened in other states too. So not trying to sound any alarms or anything like that, but it's important to note that we're still seeing Mpox cases, and they can pop up from time to time. This slide is showing our epi curve, looking at the different the onset of illness for these cases, looking at days and then also by week of illness as well. So they've been closely set together. My team is actually, and our HIV STD viral hepatitis team is looking into these cases and doing investigations, contact tracing, those sorts of things. We are seeing some epi-links among some of them. We're also seeing that some of these, at least one of these cases was fully vaccinated as well prior to the illness. So just bringing this up as a reminder that Mpox is still out there. So this outbreak, again, nationally started and including in Indiana started May of last year. As of September 28th, prior to our recent cases, Indiana had almost 300 cases, nationally over 30,000. So a lot of, so anybody could have been a part of this outbreak, but in the current outbreak that we're seeing nationally and internationally was mainly among men who identify as gay, bisexual, or otherwise MSM. And this is just a map of the country to show you where the cases were. As you can imagine, they're the highest concentrations around the most populated areas. But Indiana was among some of those in the sort of that medium to high incidence. And then just a reminder of Mpox as a whole, it is a member of the orthopox virus family. Typically what we've seen historically is it is endemic in a small number of countries within Africa. We would see sporadic cases in non-endemic countries. We would typically what we saw in the past is we would see this related to some sort of animal importation, so spreading from animals to humans. So it was usually handled by our vector and zoonotic team here. And it typically spreads by direct contact, so very close contact, skin-to-skin contact, direct contact with bodily fluids, including those lesions and lesions that are fluid-filled people. And then also potentially contact with contaminated items as listed out there. It can spread by respiratory droplets during close personal contact, prolonged face-to-face contact or intimate contact. And then infectious period is pretty long because some of these lesions actually take quite a while to resolve. So, it's infectious period is really from the onset of any symptoms. So that's not just lesions. So that could be the prodromal period where you're seeing fever, chills, headaches, those sorts of things. So potentially infectious there through respiratory droplets. So these are the symptoms. As I mentioned, the prodromal symptoms: you get the fever, chills, headache, swollen lymph nodes, exhaustion, some sore throat, congestion, cough potentially. Then it progresses into the rash, the typical rash that we think of for Mpox. So it goes through different stages and may take up to 2 to 4 weeks. As I mentioned, the actual rash itself can take quite a while to resolve, but that person is potentially infectious throughout that period. So we do have Mpox testing available at our IDOH laboratory. Individuals that are seeking care, we can take swabs from lesions for orthopox testing at our laboratory. We don't do confirmatory testing at our lab, but during the outbreak that we've seen, our laboratory actually tests for orthopox virus. It doesn't necessarily test specific for Mpox. So to get confirmatory testing, we do have to send those up to CDC. However, based on what we know at the current outbreak and sort of what we've learned throughout this and testing lots of patients throughout the country, what we use is if we have a positive orthopox result at our laboratory, we're considering that a probable case and that we're taking action on that patient, so we can actually initiate case investigation, contact tracing, control measures, those sorts of things. So post-exposure prophylaxis. So if we know somebody's been exposed, we have been able to use the smallpox vaccine, mostly JYNNEOS for that. ACAM 2000 is sort of the older version of the smallpox vaccine, but JYNNEOS is a little bit easier to provide to patients. But it can be used for post-exposure. But it has to be given really quickly after post-exposure to really reduce the symptoms. So may reduce the symptoms, severity of symptoms, and hopefully not improve the resolution of those symptoms and lesions. So again, just reiterating that the Mpox vaccine or the smallpox vaccine can be given as post-exposure prophylaxis. PEP can be given to those that have certain risk factors that may have been exposed. But this all goes down to like making sure that we as public health and as community partners, we're responding to these patients as quickly as possible, because the quicker we can give PEP, the better that the uptake for those vaccines and post-exposure treatments actually work. We also have available antivirals. So if somebody has already been diagnosed and we're past the post-exposure phase, TPOXX is available. It is a drug that we can use for this. We do have TPOXX available across the states. We had that available, but it helps to, it is recommended for people that may experience severe illness, may have risk of, have increased risk for severe illness, already have severe illness, or have lesions that are in sensitive areas specifically. But the clinicians that are treating the patients or seeing the patients are the ones that we rely on to help request those medications. So for prevention, we did do quite a bit of Mpox vaccination for using the JYNNEOS vaccine last year. As the outbreak was sort of ramping up, we did do some vaccine campaigns. We're still doing some campaigns through social media and stuff like that to target people that may be at more risk for developing Mpox lesions. This is still sort of the recommendation that CDC is behind and that we use in Indiana as well. So it is a 2-dose series, but is recommended at this time for gay, bisexual, or other men who have sex with men, transgender or gender diverse populations, persons exchanging sex for money, persons living with HIV that may anticipate possible Mpox exposures, and those living and working in high-risk exposure areas. So some laboratory workers, those sorts of things. We have a lot of this information on our MPOX webpage. We built this up during last year as the outbreak was kind of ramping up. So lots of information out there for providers and for you guys to share with your community partners. So I also mentioned I wanted to highlight a little bit of the work that the entomology team does. We do have an entomology team. I think a lot of they fall behind the scenes a lot, and a lot of people don't realize that this group actually works under our infectious disease division for a very they do a lot of important work. So trying to highlight them a little bit more, and it is information that providers should be utilizing across the state. And we are building other dashboards around some of this work that we do to help make decisions and for the public, to use as a tool, and also for providers to look at for helping to diagnose patients as well. So we have an entomology team. We have a senior entomologist, medical entomologist, Lee Green. He leads this team, and then we have 3 regional field entomologists that are out there doing a lot of this work. So what we're doing is we're doing a lot of surveillance mosquitoes and ticks to actually and then actually doing testing and doing some work to collect that information what we're collecting to help look at several different diseases, mosquito-borne diseases, as well as tick-borne diseases as listed out here. So it's really important work and some of the work that people don't realize what we're doing. So so this is the sort of the project timeline that team actually follows. So starting in March, they're already out in the field. They're actually doing tick collection. So they're looking at adult ticks and also nymphs. So the smaller early stages of the life stages of ticks. And then going into around May is also when we start looking at mosquito surveillance. That's when mosquitoes start becoming active. Typically around June is when we start seeing West Nile virus activity within our mosquito populations and pools and testing. So that mosquito surveillance actually goes up through now. About a week or 2 ago is when our mosquito surveillance actually officially ended. But then that team is still doing adult tick surveillance throughout the end of this year. As you can see from this picture, we're not just doing we are doing collection. So some of these pictures highlight some of the mosquito surveillance tools that we use. Those are actually traps that are put out in the field by our team, but also some local health departments do some of this as well. So based on the type of mosquitoes that we're seeing or trying to collect and test, depends on which traps are used, because they are attracted to different things. They have different they live in different areas of the state. So it's important to use different tools to collect the different mosquitoes we're looking at. So our surveillance network for mosquitoes specifically looks a little bit like this. So we have local health departments, like I said, they do some trapping out there, and they send those mosquitoes to us. Some of them actually do some testing in their health department as well on those mosquitoes. And then the blue highlight are some of the LHG. The yellow is the traps and testing. They actually do some testing, but then the blue is where there's additional LHD traps. And then our team actually does mosquito surveillance in every single county at some point. So they're trying to collect mosquitoes in each county in the state. We do have entomology interns. So if you have students or you know about students that would like to get into some of this work, we do hire interns every mosquito season. They help do trapping and help do some of the testing that we do in our laboratory as well. One of the important mosquito surveillance activities that we do that I wanted to point out is for Eastern equine encephalitis, or triple E is sometimes what you might hear called. Up in Michigan, so in the northern part of the states, is on that sort of that Michigan border. Michigan has quite a bit more triple E activity than we do. So we do, and the types of mosquitoes that we're trying to look for triple E testing are actually, they love the sort of that marshy bog area that's present up in the northern part of Indiana. So that's why we focus on there, and that's where we might see activity. Thankfully, it's rare that we see this, but we do see it. We didn't have any identification of triple E either in our mosquito pools this year or within horses. We also do, there's also horses can also get triple E based on, as you can tell by the name. But they can also die from this disease as well. So we do get information on testing of horses up in that area based on veterinary reporting and stuff like that. So we use some of that information to determine where we set traps, those sorts of things. So we do focus a little bit on this on the upper area because triple E, I mean, people that do become infected with it can have up to a 30% mortality rate. So it is a serious illness that we try to prevent as quickly as possible. We have done targeted spraying up in that area for killing some of these mosquitoes that transmit triple E. We didn't do that this year, but in the last 5 years, we've done that a couple of times actually in partnership with some of those counties and some of the partners up in that area. So just a summary of this year, this was actually the most mosquitoes that we've tested in the history of this program. We do have one of the most robust mosquito surveillance programs in the nation. Lee, our director for that area, he actually gets asked to present at several different conferences, even out of state, to kind of talk about some of the work that they do here. So as I mentioned, they collect mosquitoes, they pool those together based on the location. They go to our laboratory, those mosquitoes actually get ground up and then tested for specific pathogens. So specifically what we're looking for is West Nile virus, triple E, La Crosse, St. Louis encephalitis, those sorts of things. But as West Nile virus is one of our biggest ones that we look for, and we use that as an indicator of high activity for mosquitoes. But this year we actually saw our first West Nile positive pool in Clinton County back in June. So this just highlights some of the West Nile virus activity. Again, one of those things that we see a lot of. West Nile virus has been around for a long time, and I think people don't realize how severe it is and that it's still around because you don't hear about it as much. But this team does a great job of collecting mosquitoes and getting those tested. And what we're trying to do with this is actually some snapshots of our dashboard. We're trying to get this information out so we can actually highlight the counties that are seeing the most activity, and hopefully people and providers can use that data to actually inform their patients, and we can inform the public of where the activity is actually happening. So if people realize that it's actually within their county, they take this information more seriously, I think is sort of our pitch here, is that we're collecting this information for a reason, so that once we see activity increasing, we can actually push out public messaging about mosquito prevention activities, using mosquito repellent when you're outside, avoiding outdoors when those mosquitoes are most active, those sorts of things. So there's a lot of good public health measures that we can actually implement and push forward to actually use this information to its advantage. As I mentioned, that team also does tick and tick-borne disease surveillance. So these are the ticks that we see in the state of Indiana. A couple ones I do want to point out is the black-legged tick on the bottom left. That is a species that we've sort of seen grow across the state and seen it actually captured in most every county. We actually saw it. And then we use that information to actually test it for pathogens, and we're looking for specifically within the black-legged tick, Lyme disease. So we're seeing Lyme disease increase in Indiana, and that's based on just migration of the ticks themselves from different as they've migrated into Indiana, and then kind of moved from kind of essentially just spreading across the state. So the ticks are out there that spread Lyme disease. We know that, and they're pretty much in every county at this point in time. But what we do when we collect these ticks, we actually again test them. We send them to CDC for testing to look for which pathogens they may carry. So this is the bacteria that causes Lyme disease. That's the surveillance. Sorry, I moved that slide again. So this is the surveillance we do for that. So what's important to point out here in this slide is this is looking at what % of those ticks that we collected, those black-legged ticks that we collected, we found the actual pathogen within them. So you can see that some of these counties up here, not only are we collecting the ticks in every county, but we're seeing some of the infectivity of those ticks pretty high. So more than 40% of the ticks that we're collecting in some of these areas are actually are carrying the pathogen that causes Lyme disease. So again, additional information that we can use to inform the public and inform providers when they're seeing patients that may be presenting with tick-borne-like diseases. Another important thing, something else that we learned this year, just through our tick surveillance and some of the robust surveillance that we do for ticks, we had identified the Asian longhorn tick. We found it. One of our entomologists found it. Our southern entomologist, Doug Gender, he actually found it doing some of his surveillance in the tick drag. So they actually take like a sheet or like some sort of cloth, and they walk through fields that may be good habitat for ticks. And they take those ticks off of there, they ID those ticks, and then send them off for testing, those sorts of things. So Doug was able to identify an Asian longhorn tick, and why that's is important because this year was actually the first time we ever identified this tick within our state. So the important thing here is, like, we're not obviously ticks don't care about boundaries or borders, so they're going to be able to cross into other states. But you can see this tick has kind of spread across the eastern part of the country. We did find it in Indiana. As of right now, it does not carry pathogens that are harmful to humans. It has a potential to. We're just not seeing that at this point in time. But it is an important thing to know. It can carry diseases that impact cattle, though. So that is one important thing that we see. So we have worked with our Board of Animal Health with this and some of the messaging that can be around that. So it can carry diseases that do impact or kill cattle. So it is important in that aspect. So if you haven't heard, hopefully you've all heard at this point in time something about Health First Indiana. So even during the pandemic, when we still had a public health emergency, the governor forms our Governor's Public Health Commission. So that was a commission that was pulled together from people from our agency, leaders from across the states, but also some federal partners as well, former federal partners, to help put together recommendations to improve public health in the state of Indiana. So after those recommendations came out, that was then on us here at the agency to push those recommendations forward, and that changes it's no longer the Governor's Public Health Commission, it's now Health First Indiana. So this is our initiative to actually take those recommendations, push them forward. We've used those recommendations to actually work with our legislators in the states. And we were successful at getting quite a bit of money actually to put forth towards public health. And so what we're doing at our state agency is putting together those recommendations and working with local health departments to actually use that funding that is now coming into the state, or that is within the state for and dedicated for public health. So we do have a website specifically for this, so please feel free to go to this website. There's a lot of good information on there. It's simple, easy, healthfirstindiana.com, and I'll get you directed right to there. But really what it is it is a state investment. It's a state investment to local public health. So as I mentioned, there's quite a bit of funding that came with this, but it is not necessarily coming to IDOH. It's going out to our local health department partners. So this was a Senate Enrolled Act 4, so you can read more about that, but legislation passed this, like I mentioned, this year in the Indiana General Assembly. And it starts in 2024. So right now we're throughout this whole year actually been working on planning even before we got the money appropriated. We were working on planning, we're working on how to put this together and working with our local health departments to prepare for that. So this is funding that counties had to decide to opt in. They did not have to take this funding; they had to opt in to actually take it. And when they took that, they agreed to provide the core public health services that we laid out. And there's some new core services in there that we've always had at IDOH and as core services, but local health departments didn't necessarily have funding to do some of those. So this funding helps with some of that, and that includes some things that you don't typically see at every county health department as trauma and injury programs, chronic disease prevention, maternal and child health, those sorts of things. So, but essentially what this is, it's an effort to ensure that every Hoosier has access to these core public health services. that allows us as a state to improve our optimal health and improve public health as a whole. So with this Health First Indiana, we've developed 22 statewide KPIs, and these KPIs are actually divided up amongst some of the 16 core public health services that we've laid out as deemed initiative or essential. And that's the focus of these KPIs is to help over the next year or two to actually improve public health, as we know that these changes aren't going to happen overnight. So this is a long-term initiative. And then we're developing portals and stuff like that local health firms can actually submit the KPI data so that we can actually show this data in action and showing what we can do. The bill that actually passed, not only did we develop statewide KPIs, but part of the funding is for counties to actually develop their own county level KPIs. Not every county is going to be at the same they're not going to be in the same stage essentially for every single core service. So we wanted we wanted locals to be able to build their own KPIs that made sense for their community and the public that they're serving within their community, because each community may be different. And then we'll be continuing to reconvene our leadership committees as we move forward, as we learn more, as counties are working through some of this. So as I mentioned, these are the core public health services that we're looking at. So the funding that came through was sort of divided up, the core services up a little bit. So these services that are listed here, the bill actually says that 60% of the funding that we are giving to the counties has to be used for improving these core service areas. So that includes infectious disease, our area that I cover here. But as you can see, it covers several different areas across the state and across our agency. The other core services, so up to 40% of the funding can be spent for these core services. So that includes many different things, including eyelash extensions that we cover, our tattoo rules, sewage systems, pest and vector control, swimming pools, those sorts of things. So just some quick facts. As I mentioned, it was quite a bit of money. So we had we had asked for about $150 million per year the first year, which is 2024. This funding is we've been appropriated at $75 million. As I mentioned, this is all going to counties. Going into year two, which would be calendar year 2025, that funding will go up to $150 million, divided out based on population size and need at the county level. So really, this is helping to provide that investment for prevention. We're not going to be able to tackle a lot of the things and make huge changes in our numbers and our metrics right away, but this is really focusing on a lot of the prevention and improving public health as a whole. And as you can see from this map, any green, any county that's colored and shaded in green has opted into this funding. As I mentioned, this is opt-in funding. They don't have to take this funding. Which we've been very excited to share that 86 of the 92 counties have actually opted into that. So we have a couple of counties that have not opted in for various reasons. Some of these actually plan to opt in year two, which they can do that as well. Some of them felt like they needed additional time to actually work on some of their plans and kind of think through what they wanted to do with some of that funding. So on average, we had in IDOH / the state has always given counties some sort of funding, but it hasn't been a lot, and that's why we're asking for additional funding to help give them the resources to build what they need to build. So on average, we are giving these counties 6 times more funding than what they had in the previous year, or this year, I should say, compared to what they'll see next year, and it'll be even larger in 2025. So with that, so you saw that not all the counties actually accept the money this first year, but even considering all that, 96% of Hoosiers will actually be impacted by this funding. So 96% of the Indiana population is living in a county that is getting some of this funding. So as I mentioned, about $74 million. This average funding, public health funding per capita is about $11, which that doesn't include all the other public health funding that counties are moving into that. But this funding was really we're trying to bring up our public health funding per capita to where we're more in line with what we're seeing nationally. And I mentioned that 6 counties did not opt into this funding, but so they're still going to receive some of that old funding that we always gave them. But as you can see, it's not a lot of funding. It's about 300 or not quite $400,000 for those 6 counties. So right now, 78% of the funding, like I mentioned, is going towards prevention health outcomes, and then 22% is regulatory. So that would be that 40% of that funding that I mentioned earlier on core services. That's more the regulatory side. 66 counties, we already know, are partnering with community agencies in that first year to help provide core services, and that's some of the ask with this bill was to actually build that public health community. So it's not all just the county health departments doing everything. As we know that public health, state and local government, public health can't do everything that's needed to help improve the health for Hoosiers. So so we're grateful to see that they're partnering with some of the community providers that can help with some of that some of that work that needs to be done. So we've been doing some surveying with counties to see where they're at with some of their current core services and where we need to go to, and then there's also, we're doing a lot of workshops with the districts to see where they're at, see where they need additional assistance, so that our programs here at IDOH can actually assist them in thinking through what they need to do to build out some of those core services that they may not be fully rolled out yet. Senate Bill 4 also requires local governments to actually, if they're creating new jobs, that they need to post those jobs out so that people can see those. There might be opportunities for community partners to actually see those opportunities and to help assist in doing some of that work that they're asking those positions to do. So those job postings that website is being created so that those by the end of November is the target date, but so that we're meeting the requirements for that Senate bill requirement. With that, many of you probably know and or knew Pam Fontana. She's the former state deputy. She's still with her agency, and she's helping lead our new commission here that's around local health department services, and she's building out the team that you can see here. We've hired several new staff under some federal grants that we've received around infrastructure. So we've divided our state up into regions. So we now have regional teams, and these teams are not doing core service work. They're actually helping assist counties, being that liaison with our counties and helping them work through some of the initiatives that we're building out. So this is just a snapshot of how those areas are split out, and some of the new staff that we've hired to bring on here. So some of these staff had actually have been formerly working at local health departments too in different capacities, including administrative roles at the local level. So we've got a great resource of people here working on this initiative. So we have regional directors, as I mentioned. Those are the 3 there: Sheila Paul, Mike Sutton, Michelle Matern. There are regional directors leading those teams, and we continue to build those teams underneath of them. We have school health liaisons that we're working on. We're going to have regional food specialists that actually work there and help support food protection here at our agency through these teams. They're also bringing on environmental health specialists as well to help support environmental health. There's also on our HFI webpage, there's also Indiana County Health Scorecards. And this is a tool that we're going to continue to adapt and evolve, but this is a way to look at some of the metrics for each county and ranking them in a way to look at some of the different metrics. This is the defaults one, looking at life expectancy. So the darker the blue, the higher the lower the higher the life expectancy. I apologize. But you can change the different topics and look at different metrics. And then there's also county at a glance. So if we wanted to look at a specific county and look at all the metrics, as you can see here, we have metrics on there for adult obesity, childhood vaccination rates, infant mortality, life expectancy, smoking rates, suicide rates, and then looking at some injury things. Our plan is to continue to expand on this so that local health departments can actually use this and help drive some of the work that they're doing at the local level. But this was just our first initial pass at trying to get some additional information out there for counties to look at. So, so please go check out that scorecard as well. It looks like I moved one slide too far. So I wanted to touch base on the last thing I wanted to touch on today was just the changes to the communicable disease rule. I know we made some changes last year and I highlighted those in the spring, but this is really looking at some of the just moving forward what that might look like. So if you're unfamiliar, Indiana Administrative Code 410 is our communicable disease rule, and what that provides is definitions for how to report conditions, what are conditions that are reportable, why they're reportable, what are the requirements for physicians, hospital administrators, laboratories, and then in addition to that, there's disease intervention measures and control measures within that rule. So if you remember in the spring, or if you're on in the spring, some things we've changed, and this was passed pre-COVID actually, that we were allowed to pull out the list of communicable disease conditions within the rule to be able to pull those out and put those on our website as a commissioner's list, so that if things change, if we have a new condition that pops out, COVID-19 would be an example, or some other pathogen that may pop up, we do have those. We do have some work groups every year nationally that look at conditions that we may want to make reportable or make them not reportable anymore, those sorts of things. So it is likely that some of those things change from year to year. So if those things are written into a state rule, they're very hard to change and it's very time consuming. So this actually allows us to actually use our science to actually work to improve what's being reported and how it's reported. It also allows us to pull out the control measures from the actual rule itself, so that we're actually in the process of developing sort of that document that has control measures for each disease. So it's not stuck in a rule, and again, that helps us to alleviate when science changes, when testing changes, those sorts of things. We can update our control measures appropriately to make sure that we're staying up to date with science and not having to go through a rule change to actually do that. So last year we changed our timeframes, so we made it more streamlined. So we have just two categories now. We have immediately reportable conditions, and we have conditions reportable within 1 working day. We took off some immediately reportable conditions and moved them down to just within 1 working day. So moving forward, and why I wanted to highlight some of this is that starting in 2024, and sort of our new cadence is that we're on January 1, any new changes to the rule will go into effect. So if we added a new condition or new pathogen to our list, those will go into effect in January. And then any of those changes we'll announce to our partners on December 1st, so that there's about a month to plan for that. We don't anticipate lots of a need for a lot of changes by December 1st, because our ask to our subject matter experts here is to be working with our community partners, our providers, our laboratories throughout the year, if we have changes that are coming, to make sure that they make sense and that we're not creating more work or unnecessary work for those entities. And again, just a general reminder that we have 2 different lists. We have lists for healthcare providers and hospitals. So then we also have lists for laboratories. So both are reportable, even if it's the same patient and the same diagnosis. Both the provider and the laboratory has to report those to the state or to the local health department. So that's just a friendly reminder, and ask for you guys to help continue to educate our partners on that. This is just the example. This is what's posted. This is the updated list from last year that we updated. And again, we'll have a new one, whether there's new changes or not. We'll have a 2024 reportable list that goes up on January 1 of next year. And this just a reference slide and information once we send this out, that this is how you can report to IDOH. And MBS is our primary reporting mechanism for MBS users, of course, and we try to get all of our providers and providers onto MBS, whether it's electronically through laboratory reporting or manually through MBS on the front end. And then anything immediately reportable we want called into us 24/7. And that's all I had. That's the last slide. I don't know if there's opportunities for questions or not, but I'm happy to answer questions. And then also my email is listed here as well, if you guys have any follow-up questions or just want to get in touch with me. But I thank you for the opportunity today, and happy Halloween, everybody.